Good morning. It's John Bendo. Today I'm going to talk about inflammatory conditions of the spine. This should be roughly a 25-minute talk for the resident review board. This talk will focus on mostly osteoporosis of the spine and how it affects our surgery. I'll start out by talking about some of the seronegative spondyloarthropathies, and then from there we'll get into osteoporosis. Okay, first we'll start off talking about rheumatoid arthritis of the spine. I will say that spinal problems secondary to rheumatoid arthritis are way down. The incidence is down secondary to the fact that we have such good disease-modifying anti-rheumatoid drugs on the market now, along with some very effective TNF-alpha inhibitor drugs that are working very well. I will say that 20 years ago, I often would operate on cervical instability. Now it's once in a blue moon. It's really pretty uncommon at this point. The other thing to understand is that there's a relatively high prevalence of asymptomatic cervical spine instability. We often get sent patients that are about to undergo knee replacements and hip replacements, and they want the joint reconstruction. Doctor wants their spine checked out before surgery. We'll get x-rays, including flexion extension views, and we'll see gross instability of C1, C2, and the patient had absolutely no pain, no neurologic issues, and didn't even know it was present. So be on the lookout for a relatively high prevalence of asymptomatic cervical spine instability. C1, C2 instability is the most common form of cervical instability. They represent about 65% of all cervical instabilities. We know this is from joint erosion, tendon erosion, and inflammation of the segment. The most common deformity that we see is anterior subluxation, where the C1 ring subluxes anterior on the C2 ring. Remember the ADI, the Atleno-Dens interval, normally is 3 to 5 millimeters. So when it's more than 5 millimeters, that's pathologic. In order to get 5 millimeters of translation or subluxation, then you would have to assume that the transverse ligament is very attenuated and or ruptured. If the ADI is more than 10 millimeters, then we have to assume the secondary ligaments, the alar and apical ligaments are also ruptured. Rotatory subluxation of C1, C2 is less common than anterior subluxation. Remember that these patients often have significant pannus formation or soft tissue formation within the spinal canal that may be compressing the spinal cord, leading to signs and symptoms of cervical myelopathy. Posterior subluxation is less common than anterior subluxation, but the only way for the C1 ring to posteriorly sublux relative to C2 is if you would have to have erosion or fracture of the odontoid. All right. If you just had ligamentous injury, then you're going to get anterior subluxation. Posterior subluxation, you would have to have fracture or erosion of the odontoid for that to happen. The odontoid is the stop, basically, of C1 subluxing on C2. Basilar invagination, where the dens invaginates and comes up and presses on the brainstem, is the second most common form of cervical instability. And this is secondary to occipital C1 joint erosion as well as C1 and C2 joint erosion. And essentially, as the vertical height between the occiput and C2 shrinks, then the odontoid essentially rides up and presses onto the brainstem. The radiographic markers that are most commonly used to assess this are listed here. McRae's line, remember, is the AP distance at the margin of the base of the foramen magnum, and the McRae's line is drawn from the Bayesian to the Epistean. And if the tip of the odontoid goes anywhere above McRae's line, that's abnormal. Now, none of these lines in and of themselves are 100% diagnostic for basilar invagination, but there's many studies that have shown that you have at least 3 of these lines that are positive, then it's consistent with basilar invagination. The other thing to look at is the cephalomedullary angle. That's the angle between the anterior border of the spinal cord and the medulla. The angle is normally 135 to 175 degrees. If the angle is less than 135, that is abnormal and consistent with basilar invagination. The third most common form of instability is subaxial instability, and that accounts for about 15% of all cervical instability. They have that step ladder appearance below C2. There's often an association with stenosis and spinal cord compression that may or may not need to be addressed surgically. When we talk about risk factors for cervical spine involvement in rheumatoid arthritis, female gender is one risk factor. If you are positive rheumatoid factor, that's another risk factor. If you are on long-term steroid use, there's a higher incidence of having cervical spine abnormalities. If you have significant peripheral joint erosions, higher incidence of cervical spine involvement. The younger the age, the more significant the incidence of cervical spine involvement. The longer the duration, if it's going on for many, many years, then higher incidence of cervical involvement. Of course, the blood markers indicate higher disease activity, high ESR, high CRP, and other disease activities, and the disease activity score. These things are all markers or risk factors for cervical spine involvement in rheumatoid arthritis. Surgical indications for rheumatoid spine. Obviously, if you have significant pain in the neck and or down the upper lower extremity with progressive neurologic deficit or spinal cord compression, that's the most common surgical indication in the rheumatoid spine. If there's significant cord compression, progressive disability, the natural history for myelopathy is very unfavorable, and those patients really need surgery. How about patients that are asymptomatic? Well, according to the work of Scott Bowden, when he looked at x-rays and CAT scans of the cervical spine, if the PADI, which is the space, the posterior space available for the spinal cord, is less than 14 millimeters, regardless of the neurologic exam. The patient can be asymptomatic, normal neurological exam. If the PADI is less than 14, that's an indication for surgical indication for rheumatoid spine. And if you operate on these people, if the PADI is less than 10, there's a very poor prognosis for neurologic recovery after surgery. Remember, if you look at the ring of C1, they talk about Steele's rule of thirds, and basically what that is, if you look at the space within the ring of C1, the anterior-posterior space within the ring of C1, the rule of thirds is basically the spinal cord takes up 1/3, which is like 10 millimeters. The dens takes up another third, which is about 10 millimeters, and then there's space available around the spinal cord, CSF, stuff like that, which makes up another third, which is another 10 millimeters. So essentially, from the back of the dens to the back of the arch of C1, you have about 20 millimeters. So if that space gets less than 14 because of instability and subluxation or pannus, then that's the indication for surgical intervention. Let's talk about seronegative spinal arthropathies for a second. They're seronegative because most of the time these patients have a negative rheumatoid factor. Ankylosing spondylitis is very common. The other common one is reactive arthritis. It used to be known as Reiter syndrome. And the triad of Reiter syndrome, remember, is progressive uveitis, urethritis, and arthritis. That's an infectious type of arthritis, usually from chlamydia or something else causing the arthritis. Of course, there's psoriatic arthritis. These patients have typical psoriatic skin lesions. They have what's called the penicillin cup DIP deformity of the hand, very classic radiographic abnormality. These patients can often get C1, C2 instability, like most of like rheumatoids. There could be a juvenile SPA type as well. DISH is another common seronegative spinal arthropathy, and we'll get into that in just a second. These seronegative spinal arthropathies are often associated with a peripheral arthritis. Could be hands, could be knee, could be hip. They're often associated with enthesopathies, or inflammation of tendinous insertions into bone. They often have sacroiliitis, and that's a very common cause of their lower back pain. The differentiating feature for sacroiliitis in these patients are that the sacroiliitis is often asymmetrical, whereas something like ankylosing spondylitis, the sacroiliitis is very symmetrical. These patients often have an HLA-B27 allele, but not always, and there's a high association of inflammatory bowel disease with these seronegative spondyloarthropathies. So, inflammatory bowel disease, they may have back pain. If they do, think along the line of a seronegative spondyloarthropathy. Now, ankylosing spondylitis of the spine. These patients get spontaneous fusion and kyphosis. So the entire spine kind of calcifies. Their ligaments calcify, their discs calcify, and late in the disease progression, they get what's called a bamboo spine, as you can see here on the X-ray. The spine has a bamboo type of appearance with bulging out in the area of the disc spaces here. These are called bridging syndesmophytes. Syndesmophytes of other disorders are often not bridging and not linked. These are bridging and completely linked, classic for ankylosing spondylitis. These patients typically get cervical, thoracic, and thoracolumbar kyphosis. We measure the degree of kyphosis by what's called the chin-brow angle. As the patient stands up, you measure the angle between the chin and the brow and a vertical to the floor. And that's one way to measure their progression of their gaze and their disease. These patients often get symmetrical inflammation and fusion of the SI joints. And remember, ankylosing spondylitis kind of starts in the pelvis where they get sacroiliitis, then it moves to the lumbar spine, then the thoracic, and ultimately makes its way up to the cervical spine. That's the typical progression. There's a very high incidence of HLA-B27 in these patients. The other thing for these patients, you need to be on the lookout and have what says low suspicion here should be a high suspicion for epidural hematoma and fracture of the cervical spine. You should have a low threshold to get a CAT scan to visualize occult fractures in these patients. They can have, if an ankylosing spondylitis patient falls and has neck pain, it is a 3-column fracture until proven otherwise. Those are extremely dangerous. They can be associated with epidural hematomas. They can be associated with displacement and paralysis. So must get X-rays and a CAT scan on all those patients. X-rays can commonly be normal, especially if the fracture hasn't displaced, but you have to get CAT scan in those patients. And the other thing to consider is if the entire spine is fused, there's a long lever arm in C1, C2. Remember, C1, C2 is not fused because there's no disc there. So these patients can get C1, C2 instability, and be on the lookout for that as well. Now, if their spinal deformity and their kyphosis gets very, very significant, they can be candidates for a corrective osteotomy for severe deformity. Those osteotomies are typically done at the cervical thoracic junction. If these patients have what's called a chin-on-chest deformity and their spine is fused, you need to do a 3-column osteotomy of the cervical thoracic junction and get their head in an extended position and fix it with instrumentation extending well up into the cervical spine and into the thoracic spine. Remember, these patients are all fused, so you have multiple points of fixation. Their bone quality may not be the greatest, and these are long lever arms, so you want multiple points of fixation to fix these patients. When we talk about DISH, or diffuse idiopathic skeletal hyperostosis, aka Forestier's disease, this is basically a unilateral ossification of the ALL. The differentiating radiographic feature of DISH versus AS is the fact that the disc spaces and the facet joints are spared. They are not fused as they are in AS. Typically, The ALL ossification occurs on the right anterolateral aspect of the thoracic spine between T4 and T12. To make the diagnosis of DISH, there is usually a minimum of 4 adjacent vertebrae that are involved. And as you can see on the X-ray here, there is an appearance of flowing candle wax, and that's what it typically looks like. Let's move on to osteoporosis. There's a lot to talk about. The World Health Organization, long time ago, created a working group, and they utilized DEXA in their definition of osteoporosis. And osteoporosis was defined at that time, and still is, as a bone density test, or a DEXA test, at or below 2.5 standard deviations below normal peak values for young adults. What is that? How did they come to 2.5? Well, that's an arbitrary number that was chosen because the prevalence of the bone mineral density, which was done at the femoral neck in postmenopausal women, below this value, below 2.5 standard deviations, was 16% in 2 separate studies. And the lifetime risk of a hip fracture in right women was also 16%. So this DEXA number is the diagnostic threshold for osteoporosis, chosen as a point where prevalence matched hip fracture risk. And that's how they came to minus 2.5 to equate with osteoporosis. The NIH Consensus Conference in 2001 created a clinical definition of osteoporosis, which is what we still use today. And osteoporosis is defined as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. That's the simple and classic diagnosis. This chart here shows the annual fracture rates by age range among women in the USA. This is back in 2005, and you can see when you go from 50 to 64 years of age, all the way up to 85. The annual fracture percentage by age over total goes from 1.5% to almost 5%. And if you look at the percentage of those patients that are osteoporotic, we go from about 10% at the age of 50 to 64 to about 35% of patients over the age of 85. So quite significant as we get older. Now, vertebral compression fractures are the most common fragility or insufficiency fracture. They're more common than wrist fractures. They're more common than hip fractures. There's about 700,000 vertebral compression fractures that occur annually in the U.S., which is about equal to the combined number of hip and distal forearm fractures. 35% of these patients require hospitalization. The 2-year mortality rate following a vertebral compression fracture is about 1.5 times greater than the unaffected population and equal to the mortality rate following hip fracture. So it's really quite significant, not to be dismissed. Fewer than half the patients recall an inciting event causing the fracture. I see this a lot in the office. Patients will come in, back pain, and we get an X-ray and an MRI. You see a compression fracture, and I say, well, how did that happen? I don't know, doctor. I don't remember ever falling. So it's interesting. These patients, it doesn't take much. A cough or a sneeze, perhaps, that can incite a fracture. The vertebral compression fracture pain is usually posterior and can be often reproduced by deep palpation of the spinous process, because by pressing on the spinous process in the back, kind of transmits a force to the broken bone of the front of the involved vertebra, and is worsened by weight bearing. Typically, standing and flexing at the waist will exacerbate their pain. Now, in fractures at T5 and above, you may want to have a higher suspicion for a primary or a metastatic tumor. Remember, most of these osteoporotic compression fractures occur in the thoracic and lumbar spine, mid to lower thoracic spine. The upper thoracic spine, less common. If you think about the vertical kind of weight-bearing axis, as it goes from C7 all the way through the sacrum. The weight-bearing axis is anterior to the thoracic spine, right? But as you get to the apex of the thoracic spine, T8, T9, it's further away from that line, which means there's more stress and more pressure in the anterior element. So obviously, as you move away, go higher in the upper thoracic spine, it's not as far from the weight-bearing axis, and so there's a lower incidence of fracture in that area biomechanically. So once again, if you do see fractures T5 or above, you may want to rule out a primary or a secondary tumor causing that fracture, particularly solitary fractures. Remember, the truest osteoporotic fracture trauma is not required. Now, to get a morphometric fracture, the vertebral height should be reduced on an X-ray and a standing radiograph. We always get standing radiographs to allow gravity to bring out show the fracture that may or may not be, let's say, evident on a supine film. 20 to 25% of postmenopausal women have been estimated to have at least one fracture at some time in their lifetime. 1% of women at age 65 do have a morphometric fracture. 2.5 to 3% of women between the age of 75 and 79 have a new vertebral fracture each year, which is quite significant. And clinical back pain prompting a visit to a physician. The lifetime risk at age 50 in the USA is about 18%. Vertebral fractures do increase the morbidity and mortality rate of patients, and is the greatest greatest for clinical fractures and hospitalized fractures. People with a vertebral fracture are at least 5 times more likely to sustain a secondary compression fracture in the future. Now, in terms of diagnostic imaging, plain radiograph is the initial modality of choice. VCR is really defined as having at least a 20% loss of anterior, middle, or posterior column height. That translates to about 4 millimeters of reduction of height. Most compression fractures occur in the mid-thoracic or the thoracolumbar spine, as we said before, because of their relation to the weight-bearing axis. Vertebral compression fractures are described as wedged, crush, or biconcave. Wedge are the most common. Biconcave are more common in the lumbar spine. Wedge, which are the most common, are more common in the thoracic spine. And we kind of grade compression fractures as mild, moderate, and severe. Mild being 20 to 25% loss of anterior column height. Remember the 3 columns of the spine. The anterior column goes from the ALL to the mid-body. The middle column goes from the mid-body to the PLL. And the posterior column goes from the PLL to the posterior tip of the spinous process. A moderate compression fracture is 25 to 40% loss of height. And severe compression fracture would be greater than 40% loss of height. This picture further illustrates the 3 common types: wedge, biconcave, and crush. A lot of these have to do with the axis of injury and the location of the vertebra relative to the rest of the spine. Wedge fractures are the most common. Biconcave and crush are a little less common. Now, an MRI can be useful in evaluating a vertebral compression fracture, especially when the X-rays are not definitive. In other words, patient has severe pain, out of proportion, pain in all positions, no pain at rest. You have to think about fracture, especially in an elderly person. And if the X-ray is negative, I would get an MRI. The MRI would show some bone edema, which can be very, very obvious on an MRI, and that would be consistent with a compression fracture or a mild compression fracture. An MRI can also distinguish between an acute and healed fracture. Once again, if the edema is present, it usually means an acute or subacute fracture, subacute being less than 6 weeks. versus a chronic healed fracture where there won't be any edema. Edema can be seen on T1 and T2 weighted sequences. Remember, water is dark on T1, bright on T2. However, the edema is most obvious on a fat-suppressed image or short tau inversion recovery sequence, which is a stir sequence where fat is suppressed in the stir sequence. Remember, fat is also bright, so if you have an image that kind of suppresses the fat, the water will stand out more. So stir images are very, very commonly used to evaluate, or a stir sequence in an MRI is very commonly used to evaluate an occult compression fracture. And it's shown here on the right. On the left is a T1 weighted image. You can see the fracture there and the edema, which is looks dark in the vertebral body. And on the right, you see bright edema within the body. And these are stir weighted images. Classic for compression fracture. CT scan can also be useful. CT scan can determine acute versus chronic fractures to a certain extent. Not as good as an MRI, but you can see the sharpness of the fracture lines. If they're well healed and molded, then it's probably chronic. If they're acute and sharp, then it could be more acute. The CAT scan is not useful for diagnosing stress fractures as an MRI is, because especially without fracture lines or cleavage. A CAT scan may be useful, however, for studying underlying fracture anatomy before cement augmentation, before a vertebroplasty, before a kyphoplasty procedure, in order to minimize the risk of cement extravasation. If you want to see bone detail, you get a CAT scan. MRI is specifically a test when we're not assessing bone detail. So if you want to look at bone detail, CAT scan could be quite helpful, as is shown here. This X-ray CAT scan on the left, on the scout lateral here, you can see the compression fracture. You can almost see a cleft or an area of non-union. And on the picture on the right, you see a void, some gas pocket within the compression fracture, which may be indicative also of a cleft or a non-union in that vertebral body fracture. Now, how do we assess the risk of fracture, osteoporosis and estimating fracture risk? Well, it's more than just a DEXA scan. Doctors will treat fracture risk, not necessarily bone density. And what do I mean by that? Well, there's the FRAX, F-R-A-X, which is basically a diagnostic tool that rheumatologists and endocrinologists use that are assessing your risk for fracture. This is a diagnostic tool used to calculate the 10-year probability of bone fracture risk. It was developed at the University of Sheffield. Basically, you see the questionnaire there, and multiple questions, multiple parameters, approximately 10 of them. There's age, sex, weight, height, previous fracture, current smoking status, glucocorticoid use, history of rheumatoid arthritis, alcohol use, bone mineral density gets factored into this equation. Essentially, they come up with a number and they put it on a graph, and they come up with your 10-year probability of bone fracture risk. And once they put your number on a graph, that will decide how you get treated. So the FRAX is typically used by our rheumatologists and endocrinologists when treating fracture risk. This diagram here, once again, points out osteoporosis is defined by the World Health Organization as a DEXA scan below 2.5. So minus 2.5 or less is osteoporosis. Osteopenia is defined as between minus 1 DEXA and minus 2.5. And normal bone quality would be anything between 0 and minus 1. How do they arrive at a T-score? If you're wondering, well, this is the equation for T-score. It's the patient's bone mineral density minus the young adult mean bone mineral density divided by 1 standard deviation of young adult mean bone mineral density. And that's how they come up with a T-score. Once again, anything less than minus 2.5, osteoporosis. And this chart here kind of gives you a sense of the T-score and the percentage of bone loss that's associated with that T-score. So for -1, which is osteopenia, you'd have about 10% loss of bone. When you get up to -4, you could be missing about 40% of your bone at that point. -2.5, which is the threshold for osteoporosis, you're missing about 25% of your bone density. When it comes to the initial evaluation of osteoporosis, the endocrinologist and rheumatologist will often get a battery of blood work, including CBC, ESR, chemistry profile, NTX or CTX. These are a blood that represents the concentration of cross-linked polypeptides of type 1 collagen, and essentially that blood number correlates with the degree of bone resorption. So NTX can be very helpful in the initial evaluation of osteoporosis, as well as following patients when they're getting treated for osteoporosis to see what the degree of bone resorption is. Vitamin D25 is also gotten. Serum IFX. Celiac testing is another common thing when malabsorptive syndromes are considered. Of course, there's a whole battery of hormones that get tested: cortisol levels, estradiol, FSH, LH, testosterone, PTH, parathormone, phosphorus, IGF-1, and a 24-hour urine will often be collected to see what's happening with the calcium and phosphorus in the urine. Bone density, once again, gets reviewed by way of X-ray and DEXA scan, and a bone biopsy will sometimes be considered if it doesn't seem to be typical osteoporosis. Perhaps they're concerned about osteomalacia or softening of the bone, and a bone biopsy may be entertained in a situation like that. What are the treatment goals and strategies behind osteoporosis? Well, fracture prevention is obviously the mainstay of treatment. You want to maintain good bone strength. The non-pharmacologic treatment strategies include calcium, and the recommended daily dose is about 1,200 to 1,500 milligrams of calcium a day over the age of 50. Vitamin D, a minimum of 400 units a day over the age of 50. And of course, physical exercise 3 to 4 times a week, at least 20 minutes. Weight-bearing exercise is also recommended. In terms of the pharmacologics, the bisphosphonates are commonly used for osteoporosis treatment and prevention. Alendronate or Fosamax is commonly used. Ibandronate, which is Boniva, is another common bisphosphonate. The bisphosphonates basically work by inhibiting osteoclast function. They inhibit breakdown of bone. Other categories of drugs are the anabolic drugs or the teriparatide, which is the recombinant parathormone, which basically is anabolic and puts backbone and builds bone. Other possibility treatments are hormone replacement. Another common drug that's used is Prolia, which, like the bisphosphonate, kind of works on osteoclast function, but it works a little differently. It works by way of the rankle antibody, and essentially that also slows down osteoclast function. Prolia is good. It's only given twice a year, an injection. And if somebody comes in for spine surgery or fusion and their bone density is suspect, then we will often postpone the surgery, give Prolia for 3 to 6 months, repeat the DEXA, and then do the surgery at that point. So a lot of these drugs we'll get into later are also used before complex spine surgery. Osteoporosis risk factors. The primary risk factors are increased age, tobacco use, sedentary lifestyle, and alcoholism, just to name a few. The secondary factors, as we said before, are things like malabsorptive diseases like celiac disease, rheumatism, hypogonadism, and a decreased serum vitamin D level can also lead to osteoporosis. So when do we consider percutaneous vertebroplasty and or balloon kyphoplasty? These are two common procedures. A lot of surgeons, we used to do these procedures years ago. Most of them are done now by invasive radiologists. They do them in the office setting, in a control setting with biplanar fluoroscopy. Most vertebral compression fractures will heal without any main intervention. You can put them in a brace. They're treated with supportive care and some oral medications. I would say 85%, 80% clearly will heal without major issue, depending on the severity of the fracture. However, if you have an acute compression fracture, 3 to 4 weeks have gone by, the pain is intractable, refractory to non-op care, the brace is not working, medications are not working, you see progressive settling of the fracture on standing radiographs, that may be a very good candidate for percutaneous vertebroplasty or balloon kyphoplasty. Obviously, it could also be utilized in pathologic fractures, very, very good for neoplastic pathologic fractures without neural compression. Vertebroplasty and kyphoplasty have been very helpful in that respect. Remember, vertebroplasty is just done with sticking a needle into the percutaneous needle into the bone and injecting some cement, whereas balloon kyphoplasty is sticking that trocar or that needle into the body, blowing up a balloon, creating a cavity, and then injecting the cement within that. Vertebroplasty and kyphoplasty could also be used seldom in chronic fractures, ones that are greater than 4 months old. If they have cavitation, if they have significant osteonecrosis, which you can see on an MRI, if there's a significant cleft that hasn't healed, or some bone edema indicating some reactivity of the problem, then vertebroplasty and kyphoplasty may be helpful in those patients. These procedures have been associated with prolonged survival, and they do prevent morbidity. The downside, there is some literature to show that they may, which is a big exclamation point, may increase the rate of adjacent fracture. Obviously, just by having a compression fracture like this, with some loss of vertebral column height, your whole axis of weight bearing shifts anteriorly, which may further increase the stresses on the vertebral bodies, which may therein, increase your chance of having an adjacent level fracture. So there's some concern that adding cement can stiffen that area, thereby increasing the stress, the neighboring stress on the neighboring body, which may then increase your chance of further fracture. So it's certainly a concern. Now, which is better, vertebroplasty or balloon kyphoplasty? Well, kyphoplasty, the studies looking at kyphoplasty comparing to vertebroplasty have shown that there seems to be less cement extravasation. That makes sense because you're creating a cavity before you inject, before you pressurize your cement into the space. So kyphoplasty, less cement extravasation. Kyphoplasty, obviously, by putting the balloon, you can elevate and reduce the fracture somewhat if it's quite acute and fresh. So there is a greater correction of the kyphotic wedge with kyphoplasty versus vertebroplasty. Vertebroplasty is more of an in situ injection where the position that it was injected in usually stays like that. And just by giving, offering some support to the vertebral body, these patients often get off the table and feel better right away. Is there any advantage of double balloon kyphoplasty versus single balloon kyphoplasty? Not really. Most studies show that the single balloon is as effective as the double balloon kyphoplasty. Because you're not using a balloon, you're just using a needle and some cement. The vertebroplasty is less costly, however, than kyphoplasty. However, looking at all the studies and the meta-analyses that have compared vertebroplasty and balloon kyphoplasty, there does not appear to be a significant difference in the short-term and or long-term outcomes, disability status, at all between these two procedures. So that's important to note. Now, when it comes to spine surgery and osteoporosis, what are some of the things that go through our minds before we schedule these patients? Well, we know that if somebody has significant osteoporosis, and I'm talking about, minus 2.5 or less bone quality, and they're considering getting a spinal fusion with instrumentation. Well, we know there's increased fatigue failure in those patients. There's decreased screw pull-out strength, which can lead to hardware failure. There's early screw loosening, which can then lead to a higher incidence of pseudoarthrosis. And of course, as the picture showed here, with significant osteoporosis in the bottom picture there's a higher incidence of proximal junctional kyphosis and distal junctional kyphosis. So these are usually very significant problems that often require further surgery. So it's best to try to get ahead of these problems before surgery. So some of the screening and prevention that we consider prior to elective spine surgery, well, anybody over the age, let's say, of 65 for myself, I'll consider a DEXA scan before operating on them. Remember that DEXA scans are not 100% reliable either, especially if you have a very arthritic spine. There have been false negative reports. In other words, if you have significant facet arthritis and osteophytes, your DEXA scan may actually look better than it actually is. Another thing that you can consider before surgery is a quantitative CT, which is, if you can't do a DEXA, you can consider a quant CT to assess the degree of osteoporosis in the spine. The problem with the quant CT is it's very costly, and there's a lot of radiation. Now, very often on a regular CT, which we get before spinal fusion, we will look at the Hounsfield units, as shown on the CAT scan here. And if you look at the Hounsfield units in the middle of the vertebral body there, the Hounsfield unit correlates with bone mineral density. And the cutoff is about 146. So if your Hounsfield unit is 80 or 90, you know that vertebral body may not be very strong. So that's something that we started looking at before surgery. So if the Hounsfield units are very low, DEXA scan shows minus 3.0, you may want to consider perioperative medical treatment to augment the bone mineral density prior to spine fusion. And that's why we'll send these patients to a rheumatologist before surgery to get a look at them and to start a program of therapy before spinal fusion. Prolia is commonly used, as well as recombinant parathormone, teriparatide. Typically, we'll treat patients for 3 to 6 months and then operate on them. What are some of the other strategies we may employ in the operating room to diminish bone implant failure? Well, if the bone is really weak, a longer fusion construct usually provides increased points of fixation, as shown here. We'll avoid ending fusion at cervical, thoracic, or thoracolumbar junctions, which is one of the more unstable areas in the spine. By ending at a junction, there's a higher chance of having PJK or DJK. We'll often consider hybrid posterior constructs. In other words, you may have screws in part of your construct, and then you may want to go to hooks or sublaminar wires in the most cephalad aspect of the construct to offset the stress differential between the instrumented part of the spine and the uninstrumented part of the spine in order to avoid PJK. For distal fixation, we'll consider iliac fixation by way of iliac screws or S2AI screws to guard against sacral fractures. Sacral fractures are very, very common in the elderly age group with long fusions, as shown here. To increase the chance of fusion, we'll consider interbody augmentation to lower the chance of implant failure. And finally, we'll consider PMMA screw augmentation by way of cannulated or fenestrated screws, as shown down here in the bottom here. So these screws are fenestrated, and we'll put the screw in and inject some cement, and it improves the fixation of the screw within the body of the vertebra. So these are common strategies that we'll employ to diminish bone implant failure. Of course, listen, if the patient's approaching their, in their 80s, and they need a big operation. Very commonly, we know the bone is not of good quality, and we won't operate on these people. Sometimes you just need to know when to say no. And I find myself doing that more and more commonly now as I've seen more and more complications from severe osteoporosis. So it's best to document the osteoporosis beforehand, then deciding whether or not you're going to operate on these people. If you are going to operate on them, get the DEXA scan, look at your Hounsfield units. Hounsfield units can also be utilized to decide where you're going to end your fusion. I may want to end my fusion in T9 versus T10 if we think that that vertebra is much stronger than the adjacent level vertebra. So there are different strategies that we employ in these patients with osteoporosis. Okay, that's it. Good luck with the test, and we wish you well. Take care.